This patient has had a left upper lobectomy via video-assisted thoracoscopic surgery. The surgery was performed approximately 10 years ago, and therefore his left lower lobe has hyperinflated and his physical chest examination was normal. If his surgery had been performed more recently, then one might expect his trachea to be mildly deviated towards the side of the lobectomy and some reduced air entry in the affected area. There are a few important learning points from this case. Firstly, as just mentioned, in a lobectomy, physical chest examination may be normal other than surgical scars. This is an important point because if you see surgical scars such as a thoracotomy scar or VATS surgical scars, this is your clinical diagnosis, the surgical procedure itself, if the respiratory examination is otherwise normal. You should therefore offer a list of indications for the surgical procedure, and the examiner may then further question you on one or more of those indications. The other point to note here is that patients may have had surgery many years ago in your exam. Their scars may be very faded, so you will need to look closely at the patient's chest in order to identify small scars, such as were seen on this gentleman's thorax. It is important to know the different scars you may find in an open thoracotomy procedure versus a VATS procedure. In an open thoracotomy, one would expect a large scar on the lateral chest wall from about 15 to about 20 centimetres in length. You may see a smaller scar, and that would usually be due to a chest drain exit wound. In a VATS procedure, there will usually be 3 scars, the largest of which is in the lateral chest wall and is usually between 3 and 6 centimetres in length, and this is called the utility or access incision. You will usually see a further 2 scars, and together these scars will triangulate. The other scars are used for surgical instrumentation and for the thoracoscope itself.